distribution of the lectures now have changed a little bit. And we were supposed to talk about clinical applications of CT and MRI in the previous lecture, or at least one of them, which I don't think we come to. And then we said, okay, let's leave that for the next lecture. But then the change in the schedule came because of the royal decree. So I think what I will try to do is just to try and focus on CT in this lecture. Next lecture, which is going to be the 7th, I think it's going to be recorded, will be on nuclear medicine, and then I will leave the last lecture for the review. But I'll make sure that Dr. Rehan also distributes the updated schedule. Okay. So I will start by asking, do you have any questions from last lecture? The reason why I'm asking, because I don't want to build on knowledge that has not been very clear to you, but it doesn't matter. I mean, when we go through the cases, probably you will have some clarity about some of the things that were not as clear before. What I will do, I will focus on reviewing anatomy of various body parts, and I will focus on using CT for that. We will talk about appropriate radiology exam, and then we will use different scenarios to understand appropriate radiology examination. I don't want you to bother a lot about the clinical scenario. Most of these are simple and easy and straightforward, and even they are from real life examples. But I want you to focus on how to think about selecting one imaging modality versus the other. So this is a brain CT. I will take you through the anatomy, but I want you to remember whatever we have learned on the lecture when we talked about why do things appear in such an appearance. So the first thing when we look at an image in CT is to say, okay, what kind of window is this? Now, if you look in particular on this image, you can see that there are areas that are very white, and there are areas that are very black. Most of this black is either air, like for example here in the mastoid air cells or the temporal bones. Also the paranasal sinuses, like the sphenoid sinus, but also the fat in the orbital cavity. But they're very dark. So the attenuation values of fat here are not very well differentiated. And so are for air, because it fills the paranasal cavities and the temporal bone. But at the same time, we don't see the bone architecture very well. So this is not a bone window. It's not a long window. This is a regular soft tissue window. Now, when we look, and these images are taken from the top, this is about midway at the level of the lateral ventricles. And this is towards the base of the skull. And here we can see that there are lateral ventricles. This is the normal size in an adult. They appear low attenuation because they are filled with fluid. So often in a soft tissue window, fluid will appear of low attenuation, almost black, okay? And then you can see that there are different areas of low and higher attenuation. So the low attenuation, like here in the middle of the brain, and the higher attenuation at the periphery. Now, can I ask if you would know why those areas of lower attenuation appear low. Anyone can answer. Let me open. Are you putting it on the chat? Yeah, great. Okay. So fat, I'm not sure about the answer of less resistance, but I would agree that it is fat that makes it lower attenuation. So it's actually soft tissue with lots of fat because of the covering of the axons in the white matter. Sorry, I'm connected to my... do you hear me? Okay, because I changed my mic. Okay, let me go back. Sorry. Okay. So this is low attenuation because it's white matter, and the outer part of the brain, which is the gray matter, appears higher attenuation because it has less fat within it. Now, let's remember that this is an adult brain, and it could be young or old, but we have to realize that as we age, the morphology of the brain also changes. And sometimes not every abnormality we see is really due to disease, but simply because of a normal aging process. For example, this is an older brain, actually very old. And you can see that what happens is that the brain parenchyma starts to shrink. The sulci, which are filled with CSF, start to expand more. The lateral ventricles also start to expand more. So these are both normal, but for their age, for their corresponding age. So this is an adult, while this is an elderly individual. So not really a disease, but more like a natural progression. Okay. These cases that we're going to go through are going to start with most of the time an abnormality, and then I will take you through the normal image to compare. So this is a young gentleman who presented with an acute onset headache. So he was sitting, and then all of a sudden he had a very sharp, severe headache. Now take a look at the image, and I'll be opening the chat, and tell me if you can see anything abnormal. Well, yeah, I can tell you the abnormality is here. Yeah, okay. So yes, one of the answer is subarachnoid hemorrhage, and the other one is stroke. Stroke is a wider term. I'm going to talk about it a little bit. But yes, so if you look at this image, this is a normal brain, right? And it has the gray matter and the white matter, normal. But normally we should have CSF spaces. Like if I take you to the previous image here, you should be able to see normal CSF spaces in the base of the skull, surrounding the brain stem, and at the level of the optic chiasm. So there is really a good amount of CSF space, and here also in the Sylvian fissure between the temporal and the frontal bone. So we should see a good amount of CSF. If you look at this image, the CSF space, which is here, anterior to the brainstem and even posterior, is obliterated. And so are the Sylvian fissures with higher attenuation material. Higher attenuation is due to different reasons, but in this case, it is actually due to due to blood. And again, it's always good to know what a normal anatomy is. Sylvian fissures should be clear. We should be able to see them. And then the same for the C-sip spaces and the cisterna anterior and posterior to the brainstem. Higher attenuation many times is due to the blood, but obviously you can see higher attenuation because of calcifications. You can see it due to, for example, metal, etc. Let's start by asking the question. So this is a middle-aged woman. She has a few weeks history of headache. So for the previous case, because somebody was asking, this is a subarachnoid hemorrhage, okay? Usually a vascular, usually an aneurysm would rupture and that causes subarachnoid hemorrhage. Sometimes it can happen because of trauma, but most of the subarachnoid hemorrhage happens due to an aneurysm that has ruptured and bled. And it's very severe. Usually patients will either need immediate intervention or some of them just don't make it. They don't make it. Okay, so let's start by asking the question. These two images are for the same lady. She has had headache and nausea and vomiting. And the question is, what's the difference between the two images? It's at the same level. What do you think is the difference? Okay, remember, this is a CT. So we use T1 and T2 for MRI, right? We are looking at a CT image. So T1 and T2 are not applicable. Okay. So what do you think? For example, this is the falx cerebri. Yeah, somebody said more attenuation on the right. I agree. So this is the abnormality. We're going to talk about it, but let's take a look at the rest of the brain. What do you think are these white spots here and there? And why do we don't see them here? Yeah, so good. So one of you said we used contrast, so very much true. So this image is with contrast while the other one is without. Remember, we said we use contrast to improve visualization of lesions. So a good example is also in the brain. So we gave contrast in order to be able to see better lesions. And we know it's with contrast because this is the level of the falx cerebri, and usually there is a sinus. And there are small vessels also. The meninges are very rich with blood vessels. So these are actually blood vessels, and this is the sinus, okay? So this is a contrast enhanced image. Most, I would say if we bring you an image, most likely it will be annotated. But if it is very obvious, I think we're gonna, there might be a good chance that you will be asked what kind of image is it or what is the difference. But in general, we might give you the annotation, but you need to be able to pick up things like, for example, this image is with contrast. The white spots are blood vessels on the second image, yes. So these are the blood vessels. They are small, tiny blood vessels along the meninges, including the falx. So this image is with contrast and this is without. Now, this is the main abnormality. So this is a brain mass or a brain tumor. and it has a relatively higher attenuation, either because there was blood, tumors often bleed, or because it just has more tissue into it, or maybe calcification even. So this is the abnormality. It's located in the right cerebral hemisphere. It's a big mass. The bulk of it is higher attenuation than the rest of the brain, but then surrounded by lower attenuation. When we give contrast, we see more of the solid component. The rest seems to be fluid, so it's not uncommon for tumors to have both solid or soft tissue masses and fluid. And then we see again a lot of edema around it. This edema is limited by the by the white matter, and it is not reaching to the periphery. So this is vasogenic edema. Okay, so this is a tumor with vasogenic edema. We most of the time give contrast when we don't have an MRI, because MRI usually is better for brain tumors and detection of lesions. But we also use it if we want to detect more lesions. For example, if we see one tumor in the brain, the question is always, is this a brain tumor or is this metastasis from another cancer in the body? Because brain is a common site for metastasis. And in order to answer the question, we say if we see more than one lesion, then it is likely metastasis. If it is single lesion, it still could be metastasis, but then we have to think about primary brain tumor. And the reason is simply because if it is metastasis, then the chance of, or the survival of the patient is less, and you might not be able to resect it, even though now there are ways to tackle metastasis in the brain, especially if there are only few. But in general, it's a difference in management, that's why. One of you is asking, is this view looking from up? I'm not sure what is the meaning of that. Remember, these images are taken while the patient is lying flat with his or her back on the table, and their face facing the ceiling. And then they are acquired from the top of the brain all the way to the base of the skull, but in like axial cuts. So I'm not sure what is meant by the question. Okay. Okay. All right. Chest CT. So we talked about the brain a little bit, and now I'm gonna move to chest CT. Now in chest CT, let's think about it this way. We already have looked at lung window, and we said lung window allows us to see the architecture of the lung itself. So this is a lung window, and this is soft tissue window. The lung is blacked out. The bone is white, very white, and then the soft tissue is better delineated, so we see better the major vessels, for example. We can even see better the muscles, right, of the thorax. These two are axial images, so they are acquired in the axial plane. This is a coronary format. In CT, for example, for the chest, we acquired the images in the axial plane because this is how the patient is lying. So we go from the top of the patient till, or from head to foot, and we take slices. And then we reconstruct in another plane. In this case, this is a coronal plane, and again, it's lung window. So axial soft tissue window, axial lung window, and coronal lung window. Okay. This is a middle-aged woman, and she has shortness of breath for a few hours. And the question is, what is the abnormality, or what do you think is going on? So let's ask first, what kind of study is this? Okay. Let's ask the question again. Okay, so soft tissue window, agree. So axial image of the chest, soft tissue window. Anything else about the study? Is this similar to the one I've shown you before? So is this image similar to this one? Yeah, so it has contrast, agree. So this is an image with contrast, and it's in the axial plane. And you can easily tell by looking at the aorta, you can see it's very bright, right? And you can differentiate between the vessels and the surrounding structures. Now they look different. So this is a CT image with contrast. Now, this is the ascending aorta. This is part of the SVC. This is the descending aorta, and this is the main pulmonary artery with its branches. Do you see anything abnormal? It's very unlikely to be able to see abnormality in the lung when you are looking at a soft tissue window. So if I'm showing you a soft tissue window, most likely I'm interested in looking at something in the mediastinum, either the major vessels or the lymph node. It's not normal. So this study is not normal, but I'm not sure if the question is on these or on these white spots are actually the blood vessels with contrast in the lung. But again, I'm not here interested in the lung. Otherwise, I would have put lung window, right? Yeah, okay, so excellent. So someone said blood clot. So this is the pulmonary artery, and I'm gonna compare it with an image that doesn't have the abnormality. So this is the pulmonary artery, and you should see the main pulmonary artery and the branches filled with contrast. If you compare this image to this image, you actually have filling defects. You have things in the middle of the contrast, which do not appear to belong there. And this is actually a blood clot. So this is pulmonary embolism, or an embolus in the pulmonary arteries. Usually they develop in the lower extremities, people after travel or they have been bedridden for a while. And then they go through the venous circulation into the right side of the heart, into the pulmonary artery and the right side, into the right side of the heart and the pulmonary artery. In order to diagnose them, we usually do CT chest with contrast, and we aim at visualizing best the pulmonary arteries. And if we see filling defects like these, then we got the diagnosis. Okay, so this is pulmonary embolism of the chest. Okay. What kind of image do you think is this? Where is it? She has shortness of breath and fever. Somebody said pneumonia. Somebody said pulmonary edema. Okay, so let's do it the way we have done it a bit ago. So let's start first of all by saying what kind of study is it? So this is a CT, right? Right, so this is a CT, so that's the first thing. So first I have to ask myself, what is the imaging modality? What kind of study I'm looking at? Next, if it's a CT, which part of the body? Well, this is the chest, because I have the heart in the middle of the image, right? So this is CT chest, axial, agree? Some of you are answering on the chat. So CT chest, axial. Next, which window? Soft tissue, good, because we are seeing best the soft tissues, right? The heart, the muscles. We're looking at the lung, we're able to see it, but I tell you in a minute why. And with or without contrast? Yeah, with contrast. So that's great. So this is a CT chest image of in the axial plane, soft tissue window with contrast. So that's a good description of the study. So now what's the abnormality? Let's look on the left side and see. Well, the heart should be in the middle. It's a little bit displaced. Surprisingly, I'm able to see the lung. On the left side, I don't see it, which is normal for a soft tissue window. But I'm able to see the lung on the right side, which is here. And the reason, because this is not a normal lung. A normal lung should not appear on the soft tissue window. This is a lung that is collapsed. Yes, so this is a lung that is partially collapsed. And because it's collapsed, the blood vessels will crowd, so it will increase the attenuation and it would appear. So there isn't much air here, and it's becoming just like a soft tissue. So here, it is lung that is filled with air, which is outside the range of the soft tissue window. That's why you see it black. Here, there is no longer air. It's a collapsed lung, deflated, and all you see is the parenchyma with the blood vessels. So the attenuation now is within the range of the soft tissue window. That's why you see it. But you see it because it's abnormal. And then you have fluid around it. So that's pleural effusion. But you also have abnormal thickening of the pleura, which is the lining of the thoracic cavity here. So this is the parietal pleura. So one of you said collapse, I agree. But it's not just collapse. There are areas of lower attenuation. So this is most likely pneumonia. And likely that this patient have developed a complication of this pneumonia, which is empyema. So it's actually infected pleural effusion. And I say this because the pleural cavity or the pleural lining is actually thickened. And I'm going to show you here how a regular pleural effusion would look like. So this is a CT chest with contrast. This patient has heart failure and he has pleural effusions. But if you can see, these are pleural effusions without pleural thickening. So these are not infected or not complex pleural effusions. While this one is actually infected or complicated. And actually requires usually intervention. These, you just give medication and they dry out. Okay, so the diagnosis here is pneumonia complicated by empyema. This is the pneumonia with a collapsed lung, and this is the pleural effusion with pleural thickening, so empyema. Okay. Okay. So when we talked about the previous cases, what I was trying to show you also that which exam do we use for each abnormality. So when we talk about appropriate radiology examination, we often say it's an examination that allows us, or that is shown by highest level of evidence, to answer a clinical question or a diagnostic problem. Many times we use it to diagnose and initiate treatment, medical or surgical. For example, in the previous cases that I have shown you, this is a disease that can be treated by diuretics or medications, while this one most likely will require intervention either by putting a tube or by peeling the pleura. And sometimes we don't do anything, we just observe. But at the end, radiology examinations help us most of the time to guide treatment. Most of the time, the physician or you will have to define the problem. For example, it could be pain. Like, for example, the patient who presented with headache, that's a form of pain. It could be fever, or sometimes the patient does not have symptoms, but the history is that, well, he had a severe trauma. And then we think, what could be the diagnosis? For example, when we thought about in the first patient, the CT brain with the subarachnoid hemorrhage, we said, well, this patient has an acute headache, so it must be some kind of stroke, right? In the patient who had headache for some time, well, it cannot be something acute. It has to be something that has been there for a few weeks. So we think about tumors. And that's why when we saw the abnormality, we also wanted to give contrast. In the lady with the shortness of breath, we thought about pulmonary embolism. We could have done a chest X-ray, but at the end, the appropriate diagnosis is with CT. And then we will sometimes do an initial imaging modality. For example, the case I just have shown you with the pneumonia and empyema. Most likely the patient had the chest X-ray, but the patient was not improving, and then you end up doing the CT. I'm going to answer the question, what about lung abscess? Is it like edema? So I don't have a case with lung abscess, but if I take you backwards, so lung abscess basically will appear lower attenuation. So it could be like this, but usually abscesses, just like empyema, they tend to form walls. So you might see a wall to it. So this could be an area of pneumonia, and if it becomes too liquefied, it might turn into an abscess. But to call it an abscess, I need to see some wall to it. I need to see some formation of a mass-like. Because abscess is simply a cavity with pus, which is not yet the case here. I was just trying to answer one of the questions. To continue with the idea of appropriateness, we also need to think about, okay, once I have thought about what is the possible diagnosis, what imaging modality should I use? Now, today we're talking about CT, so I will cover mostly CT, but it might not be always the answer. Many times you start with a chest X-ray or with an abdominal X-ray. Sometimes you might not find a need to do anything beyond an X-ray. Sometimes you will need another imaging modality like an ultrasound or MRI, etc. Remember that we talked about imaging modalities that are better for younger patients, and those that are okay for non-young patients. For example, we said we prefer ultrasound for younger patients, and MRI, and then we say CT, we preserve it. We can do it for all, but we try to avoid it in patients and definitely in women who are pregnant, depending on the organ that we are trying to image. So there is a question, we do CT, X-ray, and MRI, why we do all of them? That's a good question. Sometimes we need more than one imaging modality to get a better understanding of the problem. Ideally, we should try and get the answer from one imaging modality, but sometimes it's not possible. So a good example is the pneumonia I just shared with you. Most probably the patient had an X-ray once, twice, and then he was not improving, and then they thought of a complication. And this is when they either start doing another imaging modality. I think I answered the question for the ultrasound, but in general, it's okay for all age groups, but we definitely in particular like to use more ultrasound than CT for younger patients. Obviously, if you don't have the modality, you're not going to use it. So you have also to work with whatever you have. So I might know that, for example, MRI is more specific and sensitive in detecting brain metastasis, but if it's not available, then it's not available. And I might just rely on CT, which is less accurate, but allows me also to detect a good percentage of the abnormalities. Urgency, you might be working in a primary healthcare center or a general hospital, and you might not have access to all the needed modalities. So it's very important also to determine how urgent is what you're doing, and or what is how urgent is what you need to do. And if it's not available in the place you are working in, then it's fine. You can always transfer the patient or send him or send her to where you think that imaging modality is available. I will show you more cases, but just as a wrap up for now, the common clinical applications of CT in the brain, intracranial bleeding and then stroke. I have shown you an example of an intracranial hemorrhage, subarachnoid in this case. In the respiratory system, we could image for COPD, but we could also image for lung tumors in the GI or the abdomen, things like acute, like appendicitis and bowel ischemia, but it could also be something that is not acute. Overall, cancers and tumors are non-acute. And I think the last lecture, I don't know if we're going to have a review or not, but the last lecture will be about cancers and tumors. And then we are going to also maybe touch a little bit on trauma, I think. I will see how time goes. Okay. Let's take a break, maybe for 10 minutes. So it's 8:42. Let's aim 8:55. Okay. later on, you're going to see that we always compare to a reference. If that reference is, if what I'm measuring or what I'm looking at is higher, we call it hyper. For example, density in CT compared usually to water, but we can also compare structures, different structures to each other. And then if it is less, we call it hypo, and if it is similar, it's iso. This is like general. What does that mean? In CT, we talk about attenuation. We also talk about density, so both of them are true. So if I look at the lesions here in the liver, I would say that these are hyperattenuating or hyperdense compared to the liver parenchyma, okay? So this is how we describe in general on CT, hyperattenuation or hyperdense. And remember that for CT, we always refer to this sort of spectrum of ounce-filled units from more radiolucent to more radiopaque. And we always think comparison to water, but we also can compare structures to each other. For example, soft tissue is hyperdense compared to water, but also to air and to fat. Fat is hypodense compared to water, but it's hyperdense compared to air. So you can always do that comparison between the structures. MRI, completely different modality. Remember, no ionizing radiation. And here we talk about intensity or signal intensity. So for example, if it is more white, we say it's hyperintense. And if it is more black, we call it hypointense. A good example is when we see the CSF fluid on a brain MRI, we say the CSF is hypointense. If there is no signal whatsoever, so very black, we call it also signal void, meaning there is no signal. But in general, we use hypointense, and this one is obviously hyperintense. So this is how we describe. In ultrasound, so that you don't get confused also, we talk about echogenicity, hyperechoic, hypoechoic, or anechoic if there are no echoes whatsoever. Iso, similar to the surrounding, hypo, less than the surrounding, hyper, more than the surrounding, and here it's anechoic, meaning there is no echoes, completely black. So just so that we get used to the terminology when we look at the cases, it's much easier. This is a normal adrenal gland on CT. So we talked a little bit about the chest and the brain. We're gonna move to the abdomen. This is the abdomen. This is an axial image with contrast. And I just want to see you that we can visualize the adrenal glands, both in the axial and the coronal plane. Obviously, these are the kidneys, and this is the spleen, this is the liver. Now, by knowing the location of the structure, we can also detect abnormality. So for example, this is a normal adrenal gland. This is an adrenal gland that has a mass. This is the location. We know it is the location because it's lateral to the crus of the diaphragm, posterior to the pancreas, and anterior and superior to the kidney. And instead of seeing this small structure, which is like a triangle, we see a large blob of soft tissue that has fat and soft tissue attenuation. So this is an adrenal mass. Okay, the next image is to compare CT and MRI. So now the left adrenal gland on the CT is normal, but the right adrenal gland is abnormal. And again, this is like a triangle or an inverted V shape, while on the right hand side, it's there is a mass. And we can see that on the MRI, the mass is seen. Now, MRI, remember, has a better soft tissue characterization and therefore might allow us to detect things like fat in a better way, even if it is very little. So even if fat is very little, we can detect it by MRI. CT allows us to see fat, but it's not as sensitive. MRI is also good to differentiate between blood and blood degradation products, etc. And I'll show you examples of these. So one of the ways to, for example, to detect adrenal adenomas, and adrenal adenomas are benign lesions, they're not cancer, but they're very common. And they're often mistaken or not mistaken if somebody is being investigated for cancer and you discover, for example, a lung mass and adrenal lesion, you always ask yourself, is this metastasis? Because adrenal adenomas, which are benign, are very common, it's always important for us to say, no, this is not cancer. This is not, this is lung cancer, but not metastasis to the adrenal, because this is an adenoma. Many times we can prove it easily on CT, but sometimes we need to do more investigation, including MRI. And this is a good way of defining an adrenal adenoma because it has fat. So we can actually apply specific sequences. They're called in and out of phase. And basically it nulls out the signal of fat. You don't need to go through the details. Just remember, we can detect fat on MRI. And one of the techniques is actually using in out of phase. Liver hemangioma is also another benign lesion. And again, not uncommonly seen. But in patients who have symptoms or another malignancy, the question is always: is this hemangioma or cyst, or is it metastasis? Ultrasound. I'm not sure if you have gone through liver lesions with Dr. Jawed, but in general, ultrasound is a good start. So here, for example, you can see there is a lesion in the liver. It is hyperechoic. We say it's hyperechoic because the echogenicity is higher. And then it also has the ability to give a posterior acoustic enhancement because it's really like a fluid-filled, very clear fluid-filled space. So it gives you a posterior acoustic enhancement. On CT, it has a very typical appearance. On CT without contrast, it will appear as lower attenuation or hypodense compared to the liver parenchyma. When contrast is given, and this is contrast given, but an image taken very early when only the aorta, so only the arterial structures are visualized, it will show filling of the space at the periphery, and then it starts to fill from outside to the inside until it's completely filled. So these are images acquired at the same location, but different timings, prior to contrast and after contrast. And we can see that hemangioma is just a blood-filled space. It is fed by an artery from the aorta, and therefore it will enhance very high early on and then start filling gradually inside until it's completely filled. On MRI, it has a very unique appearance, again, because it simulates a cyst or a fluid-filled space. It will appear hyper-intense on T2. We know this is a T2 because, for example, when we look at the spinal canal, we can see that it has a very bright signal because of the spine, the fluid in the dural space, and that appears bright. Now, I'm not sure whether you have gone through renal stones with Dr. Javed, whether on plain films or ultrasound, but in general, stones or urolithiasis can be seen on X-rays. It can also be seen on ultrasound. But nowadays, there is big reliance on CT in patients who are suspected of having renal stones. This is a normal CT without contrast. We know it's without contrast because the aorta is not opacified, and the soft tissue densities appear very similar to each other. This is a patient who has renal stones. At this image here, they are at the level of the renal pelvis. Question, is this image with or without contrast? I also don't want you guys to sleep. So with or without this image? I'm not sure what's not in the blood. It's without. So, well, one answered with, it's without. So if you look, the aorta is without contrast. You can see the muscles, but you cannot differentiate the structures very well as when you give contrast. And actually, there is a good reason why we don't give contrast, because I want to identify the radiodense or the radio-opaque stones. So if I use contrast, they will blend with each other. So I actually, on purpose, when I do a renal stone protocol, I do it without contrast to be able to see the calcifications. This is some, now remember, we could see stones on ultrasound, but nowadays, if somebody presents with an acute renal colic, we usually do CT. CT does not only allow us the ability to visualize the stones, but also complications, like, for example, here, a patient who has a long-standing renal stone, and it just caused obstruction and hydronephrosis. We can see it on the ultrasound, but we can also see it on CT. Again, masses, they could be seen on ultrasound. A cyst, for example, anechoic with posterior acoustic enhancement. A solid lesion is either iso or hyperechoic, like this one. But we will always, even if we detect an abnormality on CT, on ultrasound, and once we suspect it could be a mass, not a cyst, then we often do CT, usually with contrast. And it allows us to visualize the mass better than on ultrasound. So this is, for example, a patient who has a large right renal mass. This is a normal left kidney, and we can see part of the normal right kidney, but most of the right kidney is replaced with a large mass, which is renal cell cancer. This is a cyst. We did not need CT for it, but it's not uncommon to detect them on CT done for other reasons. But again, CT easily diagnosed on ultrasound usually does not need further investigation with CT. But if I suspect a solid renal mass, then most of the time I would go and do CT. Remember that when we talk about CT, we have the ability to benefit from the different windows. I have shown you an example of benefiting from, for example, lung versus soft tissue window when it comes to the chest, but we also have the ability to benefit from CT using the bone window. And this is in particular common when we have trauma. So this is a patient who had a trauma, motor vehicle accident. This is at the level of the cervical spine. The image is reconstructed in the sagittal plane, and we can see there is a fracture that is involving C6 vertebra. So this is 2, 3, 4, 5, 6. And there is a fragment even that is encroaching into the spinal canal. So this is a cervical spine fracture. Again, the idea is to understand what each modality can help us with. When do we use it? For example, for trauma, we often use CT because it's fast and it allows us to visualize both the bone, the lung, and the soft tissues. It does not require a lot of preparation. this is an MRI of the spine. We usually don't need it for trauma, or we don't use it for trauma because it takes time to acquire. We get similar images or similar information, more or less. For example, this is an MRI of the lumbar spine compared to a CT, and you see the lumbar spine to a better extent. Question, which sequence is this? So T1 or T2? Yeah, T1. Not T2. So remember, you always need to identify a good landmark. So one good landmark when you look at the spine is to look at the spinal canal. So this is the vertebral, these are the vertebral bodies, these are the spinous process. Remember, this is a sagittal image. And the CSF looks dark. So this is actually a T1. So T1, T2 water white, T1 water black, right? And this is a good way to contrast. Remember, this is T1 weighted image. The spinal or the dural space is filled with CSF, which is dark on T1 and bright on T2. And the same thing in the axial plane, we can see the same thing. Axial plane, vertebra, spinal canal or dural space in the middle, and you can see the space. Here you can see even the nerve roots in the middle of the dural space. So this is T1, T2, both axial. Sometimes we need to suppress the fat. This allows us to identify edema because both fat and edema can appear bright or high signal on T2 in particular. So we suppress the image of we suppress the signal of fat. So for example, if I take you backwards, you can see that the fat on T2 is not as bright as on T1 and not as bright as the fluid, but still intermediate to high signal. And the same thing in the axial plane, it is intermediate to high signal. So if I wanted to see edema or fluid, which would be very bright, I might not be able to see it good. So I suppress the signal of the fat. Now the subcutaneous fat, unlike the previous image, is actually dark. And this is simply because I suppress the signal of the fat. MRI is good for musculoskeletal injuries like ligaments and cartilage. For example, this is a normal image from the knee. It is a sagittal plane. This is the femur, this is the tibia, and this is the anterior cruciate ligament. It's low signal intensity because there isn't much water into ligaments, and it's straight. This is a patient who has an injury of the ACL, the anterior cruciate ligament, and you can see that it has lost its continuity, but there is also a lot of fluid around it. And here you can see why would you benefit from a stair sequence which suppresses the signal of the fat, because actually you get better visualization of edema. If this was all bright, you would not be able to appreciate edema as good. In the previous or before the break, when I showed you one of the images, one of you mentioned stroke. Now, stroke is a general term, and it's either ischemic or hemorrhagic. This is a good example of a stroke, an ischemic one. And basically, it appears as an area of lower attenuation area that follows the distribution of one of the cerebral vessels. So for example, this is in the distribution of the MCA, probably the commonest. Strokes take place in the MCA distribution, the middle cerebral artery. Is this cytotoxic edema? No, there might be component of cytotoxic edema, but sorry, is this cytotoxic edema? Yes. So this is cytotoxic edema in addition to vasogenic edema. But the whole point is that in cytotoxic edema, you have disruption of the vessels, of the cells. And therefore, the gray matter is also lost. So you no longer are able to see the gray and the white matter separated, unlike the vasogenic edema, where you still see differentiation between the gray and the white matter. So this is cytotoxic edema, usually with an element of vasogenic edema, but the major component is cytotoxic, and or the main prerequisite for it is cytotoxic. We have seen an example of a tumor. Sometimes hemorrhage on its own, for example, patients who have hypertension might just have a blob of hemorrhage. Whenever you see hemorrhage, be careful, because sometimes hemorrhage might hide a tumor behind it or a mass, but they all appear the same, hyperdense because of the blood and surrounded by vasogenic edema. And contrast this with the previous image. So this is vasogenic edema compared to the cytotoxic edema, which we have seen before. Again, just like elsewhere, whenever you want to assess the bone, you want to use a bone window. So this is a patient who had a trauma. So as you are looking through the images, you change the windows to assess different structures. For example, when we turn on the bone window, we are able to see the fractures better and easier. This is a patient who presented with headache, but we could not see hemorrhage, but we see a lot of vasogenic edema, so low attenuation. What would you do? What do you think is going on? So brain edema is always bad. I mean, it means there is really an injury, and whether that injury is acute, like in a stroke, or more subacute or chronic in the presence of a tumor. But many times when I see this appearance, I'm always worried that there is a lesion that I'm not able to see. So we usually give contrast, and contrast allows us to detect lesions easier. Here, I can tell you many of us would be able to detect it, but with difficulty. But here it's much easier to see that there is a lesion. This turned out to be a tumor, and the vasogenic edema is what was predominantly seen. So this is brain metastasis. MRI, we talked about that in the previous lecture. We said on a brain MRI, we see the white matter as a bright signal on T1 because it's sensitive for fat. It appears darker on T2 compared, for example, to the CSF or even to the gray matter. Now, remember that a stroke can be seen both on CT and MRI, but more sensitive or easier to see on MRI. And because it represents edema or fluid, it can be easily seen on T2 weighted sequence. And here you can see this is a good example of also cytotoxic edema. And the reason why I know it's cytotoxic because I do not, I see all the involvement all the way to the periphery of the brain. So the gyri are involved, not only the white matter. And at the same time, there is also loss of the gray-white matter differentiation, which we are able to see on the other side, for example, or in the anterior lobe and even in the occipital lobe. Sometimes we want to visualize the edema better, and we can do another sequence, which is called FLAIR. That's fluid attenuation inversion recovery. You don't need to know the name, but just to show you that MRI has better capabilities of improving soft tissue characterization. And that's usually done by changing to different sequences. Just like on CT, if we give contrast, we are better able to visualize tumors. This is, for example, a tumor, which we can see on T2 and the very severe vasogenic edema around it, but obviously better shown on the T1 weighted sequence with gadolinium. Cavernomas, so cavernomas are very similar in a sense to liver hemangiomas. So these are fluid-filled spaces. They're usually congenital. The problem with them in the brain is that they tend to bleed frequently. And this produces blood gradient or blood degradation products. Sorry, that produces blood degradation products. We can see them on T2. Remember, when blood is degraded, it will give you things like you can see that there is a dark sort of ring around the lesion. And this is because as blood degradation becomes more and more frequent, more iron is laid down, and iron acts like a magnet. So it will actually cause a signal void. But gradient echo is even more sensitive to iron and to ferromagnetic material, as we mentioned before. And therefore, it will show you even more signal voids, so more iron, but also will allow you to detect smaller cavernomas when you don't suspect them. So here you can see the big ones, but not the small ones. And when you put on a gradient echo sequence, you actually can see the lesions better. So in the brain, there are different sequences that can be used, anywhere from T1, T2, FLAIR to see edema better, contrast to identify lesions, and gradient echo to see lesions that have ferromagnets within them, including cavernomas or cavernous hemangiomas. Okay, I'm going to take you now through very quick clinical scenarios. Some of them we have gone through them, but just to get the idea of what does it mean, the word appropriate, because we talked about this before the break, but I wanted to take you through the terminology and maybe quickly compare different imaging modalities for different structures. Because I thought there might be an area of confusion there, so I wanted to clarify. So let's say somebody is presenting with cough and fever, and you think, okay, he could be having pneumonia. What would you do? Which modality would you do? Yeah, X-ray, good. Okay, so you do an X-ray and you can see the pneumonia. There is an opacity or consolidation in the left lower lobe. You don't see the diaphragm, so that's a good sign that you have consolidation. So this confirms the fact that you have pneumonia. Do you need to do anything else? Probably not. Treat the patient. And if he improves, you might want to get a follow-up chest X-ray. I'm not sure why one of you think we should do CT, not if the patient is responding to treatment. Maybe if the patient is not responding to treatment, I would do CT. But if the patient is responding to treatment, 99% that's going to be the case, maybe more. You don't need to do anything else. Okay, somebody who comes in with, he is known to have coronary artery disease and then presents with acute shortness of breath to the emergency room. What would you do? Why CT? What are you looking for? You're looking for fluid, right? And you can easily see that on X-ray. So this is an X-ray of a patient who has pulmonary edema, bilateral perihilar opacity. So these are the white areas here. You can see blunting of the costophrenic angle. That means he has small pleural effusions. You don't need CT because these patients respond very well to diuretics. So you give them diuretics and then you just do a follow-up chest X-ray and usually the abnormality would go away. Again, majority of patients will only need X-ray, no need for CT. Okay, this is a patient who has been complaining of shortness of breath for a while, and he comes back and to the clinic with repeated complaints of increasing shortness of breath. He's unable to walk. And you do an X-ray. So you think he's a COPD, what would you do? So remember, this is a chronic problem and you don't really know what is the cause of the shortness of breath. Here you can see abnormality, which is reticulations. It's like very overlapping lines throughout the lungs. So this is reticulation. But the question is, well, is this patient having lung fibrosis? Is it emphysema? Well, we cannot tell very much. So in this case, I would say we can do a CT, and the CT shows us that he has lung fibrosis, right? So in the previous two cases, we have done X-rays and it was enough in the majority of times. Here, it's different. We started with an X-ray, but we know it's not enough and we did CT. The answer, would you do always a chest X-ray and then if you need more investigation? So we always start with the least expensive, the most accessible modality, if it can answer the original question. In the case of pulmonary edema and pneumonia, it answers the question. It's unlikely to go to CT without doing a chest X-ray. I'm talking just about the chest. I mean, we do that all the time we do CT abdomen without an abdominal X-ray. We do a brain CT without brain X-ray, but without head X-ray. But I'm talking when it comes to the chest, it's very unlikely to do CT chest without an X-ray. But the most important thing is if you want to start with something and it will help you to answer the question, you can stop at it, or you can go to something that is more advanced. This is a patient who is a smoker and he presented with cough and weight loss. And the chest X-ray shows the abnormality. There is actually a nodule in the left upper lobe here, not easily detected. But in lung cancer, invariably, whether I'm suspecting it or whether I can see the lesion, you would always end up with a CT. And obviously you will do it with contrast because you also want to see the mediastinum and whether there are lymph nodes or not. But you want to characterize first the lesion on the lung window and see whether it involves the mediastinum, involves the chest wall. Is there only one lesion or is there metastasis, so multiple nodules elsewhere? So this is lung cancer. We did also talk about clinical problems in which it's not about the patient's symptoms, but more about the incident itself, like traumatic injuries. This is a patient, for example, who had a trauma and presented to the emergency room unconscious. So they did CT. What do you see? So what is this? Yeah, it's a hematoma. And where is it? Epidural, exactly. So epidural hematoma means that it is between the skull and between the dura. It expands very quickly because it's often arterial. And it takes place in a very, it's a very tight space. So it actually causes lots of mass effect on the brain. And this is why it's very dangerous and needs to be evacuated very quickly. We know it is so because it's lentiform. So usually they have this lens-shaped appearance. And at the same time, they don't cross the sutures because this is how the dura is attached. So this is an epidural hematoma, needs evacuation. The patient also had fracture in the C-spine. I've shown you an example. This one is a C2 fracture, and the one that I showed you before was at a lower level. Unfortunately, he also has a pneumothorax. It can be easily seen on chest X-ray, but sometimes require more um, imaging with CT. And even, well, this is obviously not the same patient. I just brought images to see what is the spectrum of findings that we can see in a patient who had a trauma and he underwent CT of different organs. So in the chest, you can also see dissection, which is injury of the ascending aorta. And this can be life-threatening if the patient does not get intervention early on because it causes rupture. There are some emergencies, just like the renal colic, which are more acute, but they can present in very similar ways. For example, a patient might present with abdominal pain with or without fever. And this is a presentation that could be seen in appendicitis, gastroenteritis, and IBD. If we suspect appendicitis, CT is a good imaging modality. This is a CT with contrast, obviously. You can see the contrast in the aorta and the IVC. And you can see the appendix here in the square. Normally, the appendix does not have fluid. The fat around it is clean. The appendix here has a wall that is enhancing. So it's this oval-shaped structure. The fat around it is not clean, so there is edema around it. And you can even see a small appendiculate. So this is acute appendicitis. Now, sometimes we think the patient has appendicitis, but we cannot do CT. A good example, if the woman is pregnant, for example, this is a lady who is pregnant. This is the uterus, and you can see part of the baby inside. Now, in those patients, what would be a good way to investigate them? What imaging modality you think? Well, this is MRI, but you can always start with ultrasound, right? So ultrasound is good for acute appendicitis. Now, in a pregnant woman, if she is early pregnancy, like this one, you can always start with ultrasound. And if you see the appendix, it's abnormal, you already have done the diagnosis. Sometimes the appendix is not seen well, especially when the uterus is larger because it displaces the appendix. Then you revert to MRI. And which sequence is this? So this is a coronal plane. Which sequence? T1, T2. Which one? So use landmarks. This is the urinary bladder. Fluid is bright, so that's T2. This is the uterus. And in the uterus, we have fluid surrounding the baby. So that's bright, so that's also T2. Okay, so that would be your landmark, really. Okay, sorry. So, yeah. So remember that when there is pregnancy, you always want to make sure that you avoid ionizing radiation. So in these patients, it's not appropriate to do CT. We started with an ultrasound, and then if we see the appendix, that's fine. If we don't, then we might revert to MRI. Usually T2. We don't give contrast during pregnancy, so that's another thing we need to be watchful for. So I'm not sure if this answered the question. When do we use MRI in pregnant women? Well, acute appendicitis is a good example. And as I said, usually after trying with ultrasound and see if it helps. Okay. Okay. So I have covered, I was actually hoping that I will be covering with you CT, but I ended up covering with you MRI as well, which I think is good. And I think it's also good that we brought them against each other because that gives you a better perspective. But we still have time. So if you have questions about this lecture or previous lecture, we could try and answer them now. So any questions? Okay, well, will it be more clinical questions in the exams? Well, you will get some clinical questions, but very similar to the ones that we have mentioned. So things that are not difficult or detailed, but I think you will definitely get clinical questions. But I doubt they're going to be difficult. It will be around whatever we have discussed. Okay. So we should at least have 2 more lectures together. I'm not sure about the review sessions, but as I mentioned, I'll be happy to give them if there is time for them. But the minimum you will get is 2 lectures. The next one, which is nuclear medicine, is going to be recorded. I'm trying to think whether it's easier, whether it's appropriate to give you the nuclear medicine or the imaging of oncology as recorded, because I can understand that maybe if it's a very new topic, it might be better not to give it through recording. I will check, but you will get both lectures. One of them will be recorded and one of them not, just because the timing on, I think it's on the 7th or Wednesday, I'm not sure. I already have a commitment, so I wasn't able to commit to being able to lecture online. But we'll sort it out. So if you have questions, send them through. I will send now the 2 lectures. Last week lecture, oh, not last, the one on MRI, the previous lecture, and this one to Dr. Rehan, and maybe you can get both lectures from him. Okay. Thank you.